morning, everyone. Thank you for joining us for SUHI's 20th anniversary. And what a wonderful, phenomenal, strong, inspiring speech by Dr. Maybank. I hope everyone here was able to join that remarkable talk. But again, you are in the Douglas room. So in this room, we will be talking about the evolution of the community health worker model to address social risk factors. I look forward to this next presentation, and I will turn it over to Yesenia Galvan.
Hi, everyone. Good morning. Thank you so much for being here today as we celebrate SUHI's 20th year anniversary. This is the AM session for the evolution of the community health worker model to address social risk factors. As Miles mentioned earlier, there will be someone who is monitoring the chat. So if you have any questions or comments, please feel free to put them in there and we will address them at the end of the presentation. Today's speakers are Stacy Ignafo, the Director of Community Health Innovations, myself, Supervisor of Program Initiatives, Melinda Banks, Community Health Worker 3, and Ann Grelecki, Chief of Staff Director at Catholic Charities of the Archdiocese of Chicago. What we hope you'll take away from today's presentation is an understanding of how the CHW model has evolved over SUHI's 20-year history, explaining the Connect ED program and the importance of community partners, understanding the value of SUHI's social determinants of health screening tool to address social risk factors, and describing the progression of SUHI's CHW support program. I'm now going to pass it off to Melinda, who's going to talk to us a little bit more about community health workers.
So thank you, Yesenia, and thank you all for joining us today and helping us celebrate 20 years of serving our communities. It's really an honor to be here with you today to also celebrate the evolution of our CHWs, not only at SUHI, but across the nation. Again, my name is Melinda, and I have been a community health worker here at SUHI for almost 6 years now. So a little bit about Sinai Urban Health Institute. Sinai Urban Health Institute, also known as SUHI, is the community engaged research arm of Chicago's largest private safety net health system. SUHI has utilized community health workers to address health inequities for over 20 years now. And in this picture, you can see some of SUHI CHWs during one of our group photo shoots. And we currently have 11 CHWs, and continue to grow. And in this picture, you'll see our SUHI family. We've grown substantially since this photo was actually taken, almost 2 years now, and how time flies. We have a little over 40 staff members now, not including the interns and the fellows. So now I'm going to talk a little bit more about the role of the community health worker. So community health workers are critical liaisons between patients and their healthcare team. Through our shared lived experiences, we understand the needs and barriers of the community, and we try to bridge that divide between the clinical staff and the patients. Because we share some of those common grounds with our patients, CHWs are often better able to establish the relationship of trust needed to successfully identify and address barriers to prevention and disease management. Now we have taken it a step further where we serve as a liaison between health, social services, and the community. So in this graph, it shows the different levels of settings in which community health workers serve our patients. The settings range from community to clinical, and in the middle we have our patient-centered community responsive models. Throughout all of this, CHWs aim to bridge the gap between the patients and health services, and we do this by being those agents of change. So those agents of change, right? In this image, the community health workers in the center, communities and health and social services are to the left and the right, and we are bringing them together, we're connecting them. So we are able to accomplish this by building individual and community capacity, advocating for individuals and community needs, providing direct services, promoting wellness by providing culturally appropriate health information to clients and providers, and by assisting patients navigate the health and human service systems. Our community health workers have the knowledge of the community and the passion to help others. SUHI further prepares the CHWs to assist our communities by providing them with an extensive multi-dimensional training, which includes cultural humility, motivational interviewing, goal setting, disease management, and prevention. So why CHWs? By using CHWs in any of these settings previously mentioned, it has been proven that CHWs are effective in reducing costs and increase client engagement and satisfaction. CHWs address health and social inequities that patients may be experiencing. We are connecting our communities and service providers. CHWs help increase knowledge and self-sufficiency of the communities through 6 core functions. And those 6 core functions are outreach, navigation, education, informal counseling, social support, and advocacy. And in this picture to the right, you will see the lovely Miss Madeline providing asthma education to one of her patients in his home setting. So SUHI has always understood the value of having community health workers. That, combined with our focus on communities, has enabled us to be at the forefront of the community health worker movement, making us a nationally recognized expert in designing CHW interventions, right? And in the center here, you'll see Gloria Seals, who is our CHW supervisor. She was SUHI's first community health worker when they had implemented the asthma intervention. So Gloria continues to share her wealth and knowledge and mentor our current and future CHWs. Gloria is truly a gem and an example of all those great qualities and dedication that it takes to make a change in our communities. So we continue to learn, and as we go, we have broadened the scope of what CHWs were initially doing. Our CHWs are cross-trained, giving them the ability to move back and forth between the programs. CHWs are more knowledgeable so that we are able to assist patients, especially those who are medically complex. So 20 years ago, our CHWs were implementing the intervention, and today our CHWs take part in the design, development, and implementation of our programs. Our senior CHWs assist in the development of protocols, trainings, and onboarding new CHWs to current programs. In the top picture, you'll see myself, Madeline, Adelaide, and Ideen. Some of our senior CHWs, and on the bottom, you'll see Ideen in action. So let's take a quick look back at the evolution of some of SUHI's CHW-led interventions, and Yesenia will talk a little bit more about that.
Thank you, Melinda. Okay, so as Melinda mentioned, we're going to take a little walk back. Ooh, it's the slide before this, though. Sorry. Thank you. Okay. So as Melinda mentioned, we're going to take a little walk back through some of our past and present interventions. Of course, we have to begin with asthma. Asthma was the first CHW-led intervention at SUHI. SUHI has been testing CHW-led asthma interventions for 2 decades. Initially, it began as clinic-based and then expanded to home visits. 9 studies have been built on the lessons learned via its predecessors. Findings have shown that, of course, CHWs are immensely effective in establishing relationships of trust. There was also consistent evidence of improved asthma control, with asthma ED visits and hospitalizations down by 50 to 80%, a decrease in system frequency, and overall improved quality of life. The CHW approach is associated with significant cost savings of $3 to $8 per every dollar spent. So by now, SUHI's work in asthma had been going on for some time, and with the documented disparities in breast cancer mortalities and the tremendous outcome from the asthma program, Helping Her Live, or HHL, was created. HHL's goal is to improve breast cancer outcomes and reduce inequities through outreach, education, and navigation in community settings. Since then, over 15,000 women have been educated and over 4,300 women have been navigated to mammograms. HHL CHWs work collaboratively with clinical navigators who are monitoring and following up on abnormal mammograms to navigate through diagnostic and treatment process. Prior to 2005, 30% of women with abnormal mammograms did not return for further diagnostics or treatment, but that was reduced to less than 5% with navigation. HHL is still currently active, and we are working on protocols to expand HHL to include cervical and colorectal screening navigations as well. Diabetes on both the management and the prevention end, because we can't just do one without the other, right? So for our management end, we utilized a community-based approach, which included surveying the community, outreach, education, going into homes to help patients best manage their diabetes. This showed decreases in A1C levels alongside improvements in self-care activities such as foot care and exercise. As well, also a pilot project was also launched, which included integrating the CHW and technology with the clinical team. On the prevention end, we are currently working with the Chicago Cares to Prevent Diabetes, which is an initiative of the Chicago Department of Public Health. This is a CHW-led evidence-based diabetes prevention program where our lifestyle coaches are our CHWs. And so our coaches are focusing on incorporating lifestyle changes such as eating healthy, increasing physical activity, and managing stress. A really, really big thing that just happened for us is we just achieved CDC preliminary recognition, which is required to become a Medicare DPP supplier. So the options are endless for us right now. We have a lot going on, and we're about to do a lot more with this, I feel. Oh, it's one before this, sorry. The slide before, there we go. Thank you. Complex care. So one thing that has been clear throughout all of our interventions is that there isn't just one thing that patients are dealing with. So SUHI decided to convene a group of organizations and CHWs to develop this complex care model, which was developed and piloted in 2018. And the model targets community members and patients that have multiple chronic conditions and unmet social needs. We also are now leading a new initiative that will be integrating this model into North and South Lawndale, and are exploring areas within the health system to integrate the model as well. Screening for social determinants of health. In 2019, CHWs began assessing health-related social needs for patients in the ED. This quickly expanded to inpatient floors, so we were no longer in the ED, we were now on other floors. And then COVID-19 hit. And again, we had to pick things up and switch and move all around again. And we partnered up with social work and began screening to provide support to patients who were being discharged with a COVID-19 diagnosis. But that wasn't enough for us. We then also started working with patients who were deemed to be high risk for readmission. So this is what's currently known as the CHW support program. We will be talking a little bit more about this as we get on further in the presentation. So no worries. I know how exciting it is to hear more about it. There will be more. So this is what, as I mentioned, it's our CHW support program. And all of this amazing work is currently being leveraged through an important partnership with Catholic Charities and other Westside healthcare organizations, known as Connect ED. And today we do have one of our community partners from Catholic Charities, Anne Grelecki. She's the Chief of Staff, Senior Director of Executive Operations and Planning, and she's here today to talk a little bit about Connect ED.
Thanks, Yesenia. I appreciate the invitation to present, and I'm so excited to talk about this program. It's really something that I find super unique and that I have the opportunity to be involved in through different roles I've had at Catholic Charities. I've been able to stay connected to this partnership, and it's been super meaningful for me. So within Westside Connect ED, as you can see on the screen, there are several other partners that are involved, and our primary healthcare partners are Sinai, Rush, Amita Health, and UI Health. And then we also have Illinois Partners for Human Service on board as well. And the executive director of that group really makes sure that we keep a focus on connecting to other community-based providers in the area. So let's talk about how we got started, the origin story. So our story begins in January of 2016, which feels like an absolute lifetime ago. And we got together for two reasons that bring so many groups together: money and desire or passion. So a grant opportunity became available to us through Accountable Health Communities that was put out by CMS. And Rush reached out to Catholic Charities and asked if we wanted to partner on putting together an application, since we'd had success pursuing this kind of funding in the past through CMS. So the point of this grant opportunity was really to bridge the divide that exists between healthcare and community-based providers. So it made sense that a community-based provider would partner with a healthcare institution to pursue this funding. And as we looked at what was available and what we wanted to do in the community, we thought it shouldn't just be Russian Catholic Charities. There are other healthcare providers in the area serving the same population and experiencing the same frustrations. So the point of this grant really was to look at screening for health-related social needs and seeing if we screened patients for those needs, connected them with what came up as something that would help them, made actual referrals and made that actual connection. Would it, one, reduce healthcare utilization costs, and two, improve the quality of health for the patients that we were screening? So the sad news is that we did not receive this funding, and it was heartbreaking for me as one of the grant writers, and it was a huge collaborative effort that we put together with so many community providers got involved and the different hospital partners. I think still it was one, I've had 20 years of grant writing experience. This was one of my absolute favorite grants to write. And not just because I think it turned out very well written, but just the amazing partnership and collaboration among the 4 hospitals that were involved. It was so impressive to me to see that organizations that typically compete, I mean, you know, I come from a community-based organization, so I always thought, oh, hospitals must, you know, go up one against one another, you know, they're trying to get the same patients, and maybe that's the case in some circumstances, but I absolutely did not see it with this partnership. We were looking at really making a difference in the community and recognizing we are serving the same people in our emergency departments with the same needs month after month. And how can we come together to make a difference? So when we were looking then at kind of revamping, all right, so we didn't get this grant, but what can we still do since we've got so much momentum and such a strong partnership already built? Let's really focus on a certain community. So we looked at the west side of Chicago, which is kind of where we started when we were pursuing the initial grant, but truly targeted it to certain zip codes in the area and looked at what are some of the issues that this community faces related to healthcare, related to economic challenges, social challenges, and inequities. And data was showing us that there's a 16-year gap, and this was, you know, a few years ago, so I'd have to update my numbers, but 16-year gap between life expectancy with people that live in the west side of Chicago and those that live in the downtown loop. And within that west side neighborhood, at the time we wrote this proposal again, so a few years ago, but 60% of the households had expressed that they were experiencing rent burden. 21% of people in the community had issues with food security. Poverty rates are higher, the crime rates are higher, and we knew this was an area that really needed some investment. And that's, again, why we decided to focus on this area. Plus, like I said, we had the amazing partnership already built and wanted to really keep that momentum moving forward. So with our passion and our lack of money, we were like, what can we do? How can we articulate what it is that we want to move forward? So we came up with a vision, we came up with a mission, and we thought these are 2 things that we need to really solidify the work of this group. So together we were looking at how we can reduce the health inequities in the targeted zip codes by bridging the divide between the clinical healthcare delivery system and the community providers in that area by strengthening collaboration across these sectors with that vision, that shared, true, and pure goal of creating healthier people and more equitable communities on Chicago's west side. So we thought, all right, our goals before when we had this, we thought we were getting this money. So our goals were a little bit loftier, and then we needed to revamp and figure, all right, let's target this. What can we specifically do? So we decided to focus on emergency departments and starting our screenings in the emergency departments, because like I mentioned, we knew that the hospitals were seeing the same people in their emergency departments across institutions at multiple times. So we thought these individuals are not coming in because they have just a health issue. They have issues that are related to something that happens once they leave that emergency department. We can make a diagnosis and send them home, but where are they going when they get home? Do they even have a safe home to go to? So we wanted to create an opportunity to facilitate easy navigation with the hospital and the community settings that included a warm handoff. So we weren't just saying to the patient, look, it seems like you need food. hope you can find some food in the area, but rather this is the specific food pantry that is closest to you that is going to be able to help you. Here is how you get there. I'm going to alert that food pantry to the fact that you're coming. So they knew that there was going to be this connection between once the person left the hospital and getting those services in the community, and really establishing a strong partnership between the hospitals and the providers. We also wanted to promote earlier intervention. So someone's coming into the emergency department, they have an obvious immediate need. This felt like a great opportunity to intervene and say, what else can we do for you while you're here? And I've been so impressed with I'll talk about this in a minute too, but just the community health workers that are able to take the time to sit with the patient, and instead of just giving a handout and saying, these are the resources in your community, but really engaging in a true conversation with this person, building trust with them to say, what else is it that's going on? What else can I help you with so that you're not back in this department, in this emergency department next week or next month? So looking at how we could improve health outcomes, and again, creating cost savings for the patient and also for the institution. So our strategic priorities that we were looking at, we've got 2 on here. I think there is a third that I'm going to pull up on my screen so I don't lose track of what that is. So let me just open that up so I can see it as well. Okay, so we've got 3 strategic priorities that we're trying to pursue through this initiative. First is implementing that social determinant of health screening and really coming up with a standardized tool that each hospital was going to use to ask the same questions, to ask about transportation, housing, food, utilities, and access to primary care. Now, the method for implementing that screening differs from hospital to hospital as it works based on your emergency department. Emergency departments can be pretty nutty. I've been in them just as a consumer sometimes, and sometimes they're calm, sometimes they're nutty. There can be a lot going on. So allowing each institution to determine when is the best way to approach the patient, what is the best format and the best timing to have that conversation. Secondly, again, increasing those connections between emergency departments and community-based organizations. And then our third priority is really collecting the data. We wanted to prove that this collaborative works. We wanted to prove that asking about the determinants and connecting people with the resources and then following up on that is really a successful model. And right now, Westside Connect ED is fortunate to partner with SUHI to start collecting some of that data to really show that we're making a difference. Then we're going to look at some key components that have made this project a success. And over the last 5 years or so that we've been implementing this, there have certainly been starts and stops. No, I wouldn't say starts, but stops. There's been starts, there's been pauses, there's been hiccups and hurdles, and certainly COVID hasn't helped. But I'm truly amazed also at the creativity of the group and really thinking about, all right, so let's pivot. This hasn't worked, or this worked last year and now it's obviously not working this year. Let's pivot and figure out what we can do to keep this going. So starting with some basic protocol on establishing that screening and those consistent questions, that's really going to help us when we're trying to do the research, making sure we're asking the same questions and getting at the same social determinants of health. We also needed to assess hospital readiness. So we had a great group of people at the table, some of whom could make decisions for their hospitals, but some of whom also needed to get buy-in from chief officers and leaders at the hospitals. So we were kind of the champions at the table, but we needed to get buy-in from those, not only those above us at the highest levels of the institution, but also those that were going to be doing the work. So we went back to, and I'm impressed how Melinda mentioned this, I think this followed as well. We went back to the individuals in the hospitals that were actually going to be doing the screening and to say to them, you tell us what's going to work. You indicate what's best for your workflow. We can design it all we want while sitting around the conference room table, but when you take it back to the hospital, you got to make sure that it's going to work. So we really did that hospital readiness at both ends of the organization. We created that creation of the screening tool was a lot of conversations. We really need to focus on which needs we're going to address. And there's been a lot of conversation on how we should include behavioral health needs. And I am 100% on board with that as a social worker myself. Yes, that needs to be addressed, but we needed to start with what we could manage, which is why we focused on the 5 primary needs that we did. And we turned it over to the community health workers and those in the institutions that are going to be asking the question and really focusing on this person-centered care. I really believe that starting the conversation, sitting down with the person, and of course now it's over the phone, but we're still making it work. But just to have those personal conversations and get to a point of trust where the patients are willing to disclose what else it is that they need. We're using high tech, high touch opportunities to do this with the personal connection, then also going back into the medical records and using these referral platforms that allow us to make instant connections with community-based providers to let them know, I have a patient here in the hospital, they need this service, I'm going to be sending them over to you. Making sure that we did follow up as well. This is another key part that the community health worker does, following up with individuals to say, did you access that referral? What worked, what didn't? And if there were challenges or barriers, let's figure it out together. Is there a transportation concern? Are the hours not working for you? What is it that we can work together to overcome those barriers? And really making that warm handoff to close the loop and say, someone did get the services that they needed because we made that connection and kind of walked them through the process. And then closing the loop will help us again with that data connection and collecting our data. And then lastly, I just brought this up too. I think this is a really amazing piece that came out of this partnership. We were able to work with the Illinois Health and Hospital Association to develop a playbook so that this can be replicated not just across Illinois, but across partners that are in the Great Lakes area. We've got hospitals in Wisconsin, hospitals in Michigan that are trying this out as well, that are looking through how it worked for us at Westside Connect ED. And we're totally upfront with, these are some of the hurdles that we experienced. This worked here in this community, this didn't, but just kind of putting that out there so people have a guide. So that's been a really cool and tangible resource that has come out of this partnership.
Thank you so much, Anne. We appreciate you being here. We also appreciate you being one of SUHI's partners and for giving us the opportunity to go through with Westside Connect ED. So I'm going to talk a little bit more in detail about the CHW support program, which is what Anne was mentioning a little bit ago right now. So as Anne mentioned, we did a lot of pivoting, so much so we've gone through 3 phases. Our first phase began in March of 2019. We had our CHWs in the ED, which is the emergency department, and outpatient floors. They were working with victims of non-fatal gun violence and trauma patients. Our second phase began when the stay-at-home order was put in place and we began working from home. So in May of 2020, we began working with patients who were discharged with a COVID-19 diagnosis, and those were referrals. We were getting referrals from social work at both Mount Sinai and Holy Cross hospitals. And then phase 3 began shortly after our phase 2, where we began working with patients who were deemed to be at high risk for readmission. Again, still referrals from the social work team at both Mount Sinai and Holy Cross. And with doing this, we were trying to intervene as soon as possible in order to address the needs of the patient and also to lower readmission rates. So a little bit of background, excuse me. In 2018, SUHI's evaluation team was exploring trends in non-fatal gun violence and the response to gun violence in Mount Sinai's hospital's emergency department. One of the challenges identified with significant opportunity for intervention was with the victims of non-fatal gun violence who were superficially wounded. So due to the superficial nature of their injuries, these patients would enter the ED, they were clinically assessed and given treatment, and then they were discharged. And within this time period, since the patient is never admitted to an inpatient unit, there was a little opportunity for staff to implement social assessment. And so this is where we wanted to fill that gap with our CHW workforce, to utilize that screening in order to screen patients and see, hey, what's going on? What can we help with?
Okay, so a little bit about the social determinants of health screening in the ED. So to the right, you can see what our MAP process was, and this is how we expected the flow to go. So we wanted to meet the patient in their room and assess them and then connect them to the resources you see here. So primary care, housing, job training and placement programs, support for substance abuse, social justice services, mental health services, and enrollment in public benefits. So we expected this pretty cake, right, to the right. So in the beginning, we expected it to be part of the ED flow, right? Working alongside the ED staff, identifying and screening non-fatal gunshot victims, assessing social needs of these patients and the gaps in the services, provide resources and referrals through a warm handoff by the ED staff. But the reality was this pretty cake. It was hard for us to find a right moment to screen and approach the patient. We were trying to connect with them when they were, at a most vulnerable moment and surrounded by clinical staff. They were being taken in and out of the exam rooms or sleeping, right, because they were tired. It was also difficult for us because we were experiencing trauma ourselves, being in the ED, witnessing some of the patients go through drug overdose to, patients being brought in with multiple gunshot wounds. So even now, it's a little bit overwhelming, even though we are virtual, because we're still making the connection, and sometimes our patients don't make it. So while being in the ED, the CHWs were able to connect and get to know the ED team well, so including social work team. Excuse me. And this is where we found our champion, Nelly Garcia. She is a surgical ICU social worker. And Nelly was instrumental in helping us branch out from the ED to the inpatient floors. And Yesenia will now talk a little bit more about that.
So our partnership with social work was most certainly a game changer for us. And Nelly was very instrumental, as Melinda mentioned. After seeing a couple of the things that we were seeing in the ED and knowing that, the CHWs were feeling a little bit of anxiety being down there, we wanted to switch things up a little bit, but also still continue to provide services. And so we expanded to other areas of the hospital. We were no longer just in the emergency department. We were on the step down unit. We were in surgical intensive care unit. We were on the second floor, on the 6th floor. We were all over the place. CHWs were providing services on just so many areas of the hospital at Mount Sinai at the time. And so what this consisted of is they were going on daily rounds with the social work team, and the social work team would assign patients who were in need of additional services. And so a CHW would go into the room after being told, hey, patient in room 2-1 wants to talk to someone, they need services. The CHW would go in, they'd screen them, provide referrals and resources as needed. What they were noticing is that patients were more willing and able to talk on the inpatient floors than they were down in the ED. And then also through this, we had more system integration, which is one of the great things. We were utilizing electronic health records. We were in our systems in Midas, NextGen, Meditech, making appointments for patients, following up, and we had access to all necessary patient records. And this was a pretty big thing for our team. Okay. So for the CHWs, and I guess I realized what happened. It didn't come out. We had a really nice, pretty graph for you like Ann did, but it didn't come out, and that's okay. You guys get to see our bullet points because the information is what is important. And so this is what it looks like when someone will send us a referral. So the social work will send a referral to me. I will then assign the case to a specific CHW based on, workload and if it's a Spanish or English speaker. The CHW will receive the case and review the patient file and discharge paperwork. And then the CHW will follow up with the patient virtually. And that can be through email, phone, telehealth, smoke signals, whatever we need to do in order to provide those referrals and resources as needed. And this is a quote from Phyllis Martini, who's the system director of case management. We work very closely with them, obviously through social work. She said, the community health workers from SUHI have been a tremendous asset to the inpatient and emergency department social workers at Sinai Chicago. It has been a comfort to know when a patient is going home that there will be a caring, compassionate, and well-versed individual that can assist with navigating the health and social needs of our patients.
Okay, so a little bit about the screening process. To the right, you'll see the first half of our screener. And the screener has helped the community health workers to collect the information, screen patients for services needed, connect patients to the PCP, follow appointments, completing and submitting the paperwork for medical insurance and emotional support. When our community health workers support program first started, a lot of our patients needed assistance with billing and submitting their paperwork for medical insurance and emergency medical insurance. So one of the biggest barriers was language. Trying to connect with outside vendors became a big task for some of our patients, and it could take up, up to weeks, right, before they heard back from someone. So by using the screener, my colleagues and I were able to provide the patients with any resources or supplies that they may need. And I want to share an example with you guys. Just last month, I was able to connect two patients, right? One needed adult diapers and another one needed a walking cane. So I was able to connect them with Catholic Charities at St. Sabina to acquire these items that they needed, these supplies. And they were so grateful, and they both stated that these supplies helped them feel a little bit more complete again.
And so this is just some data that we've been collecting as we've been going through the process. As you can see, social work has referred about 648 patients to SUHI for screening since July. CHWs have successfully screened 285 of those patients. So this means social work is on track to refer nearly 1,000 patients for the year, and CHWs are on track to screen over 400 of them. Food insecurity, behavioral health and emotional support, as well as other, which includes follow-up appointments and billing assistance, have been the highest needs that we have seen. And so something that is noteworthy for us to mention is that for patients who have been screened by, who have not been screened by a CHW, their readmission rate was at 43%, while patients who have been screened by CHWs, the 30-day readmission rate was at 31%. Now, while we do know correlation does not equal causation, it's still a really good thing to see, right? That those who are getting screened have a smaller percentage of those who are not being screened. And so now I'm going to pass it off to Stacy to talk a little bit about the future directions and our next 20 years of SUHI.
Thank you, Yesenia, Melinda, and Anne for such a wonderful presentation. I am really always in awe about the work that SUHI and our CHW, our Community Health Innovations team, has been able to do over the last 20 years. And we have so much in store for the next 20 years. And if I really had to boil down our future direction into one sentence, it would really be to build a sustainable workforce from the community for the community, which is the CHW workforce, which is what we've been doing. A key component of our future direction does involve sharing our knowledge, our lessons learned, helping to build the community health worker workforce, both locally and nationally, as that key component of reducing health inequities at the community level. Throughout our 20-year history, which has really been demonstrated in this presentation, SUHI has become a nationally recognized expert in the CHW model. And through CROWD, which is our Center for CHW Research Outcomes and Workforce Development, which we launched a few years ago, our aim is to really transfer this deep knowledge to other organizations and individuals through effective training, ongoing support for the workforce, consulting, and also providing direct service on behalf of partner organizations. Next slide, please. We do aim, over the next 20 years, we do aim to continue integrating these proven models that we've talked about today into Sinai, Chicago, and other organizations that want to integrate these models, but also really testing the CHW model in new ways, such as in the areas of behavioral health, maternal child health, primary prevention of lead poisoning, supportive oncology, and many others that we are actually engaging in right now. But also integrating the CHW model into new settings, such as schools, working closely with Chicago Public Schools and our colleagues at the University of Chicago, and really helping to transform neighborhoods through a well-trained, supported, and coordinated CHW workforce. Importantly, we are going to continue our work in communities to help support the pandemic response. And we do have a session a little later today that is really focusing on those efforts. You know, all of this is with the goal of building that sustainable workforce from the community for the community. And we don't do any of this by ourselves. We look forward to developing innovative partnerships with you all. I know I see a number of partners in this session, and for those of you that we're not currently partnering with, we look forward to initiating those partnerships and really enhancing those innovative partnerships with both community members, community organizations, and other organizations to build and carry this work forward. You'll see some of these future directions on this slide. And when I say this is just a drop in the bucket, this is just a drop in the bucket. So we look forward to really connecting with you all, and thank you for engaging in our work. And I know we're going to be opening up things for questions. So
Fantastic. Thank you so much, Yesenia, Melinda, Ann, and Stacy, for all of your phenomenal work. A good amount of questions have come in, so I'm going to start with our first question. How many times does a CHW follow up with a patient who has been referred to them through the CHW support program?
I think I got, oh, you got, go ahead, Melinda.
So we are to follow the patient for a month. We try to reach out to them and we give them about a month.
Great. Awesome. Thank you, Melinda. Our next question is, how do you coordinate your work with violence interrupters who are also in the emergency department with victims of violence?
Stacy, you might remember the name of, I cannot remember who we were partnering up with. They were violence interrupters that we were talking to down in the ED to try and see how we could best, there you go. That's exactly it. Thank you. It just popped up in the chat.
yeah, I think, when we were physically in the emergency department, we were, partnering with ACLIVIST to provide the violence interruption services. Since then we have been working on engaging with our trauma coordinator a bit more. And, quite honestly, I think we need to work out some of those synergies and partnerships a bit more. And that is part of, the future direction, is we want to be able to have this coordination among some of the other organizations that are really working with our trauma patients, both internally and externally. So that definitely is a future direction for us, because we do want to maintain those partnerships and make sure that we're addressing the needs of our patients in the most effective way.
Awesome. Thank you, Stacy. And for the group, if you didn't look into the chat, the organization was ACLIVIST. Great. So our next question is, do you help victims of violence sign up for crime victim compensation funds?
We do help them with the application process.
Do you want to dive into that a little bit more?
So it is an application, I guess, by the city of Chicago for the gunshot wound victims. So I don't remember the amount, but it's a funds that are available to anyone who has been a victim of violence, right? Specifically gunshot wound victims. And we also have our connection with domestic violence, who, her name is Audrey. She has connections also with the offices. So she's also someone who helps us with this, 27,000. So she also helps us with the application process.
Great, awesome for the detail, Melinda. Have other CHW models you looked at developed specific mental health tracks, similar to the complex care track?
Yeah, actually, that is something that we are working on right now. We have initiated there are a couple of things happening. One is we are developing some training and career pathways around population health. And one of the things that has come out loud and clear among some of the partners we've convened around this is the need for this behavioral health track. And so we're really excited to be initiating a partnership with NAMI to help kind of work through that. So we are developing a CHW training related to behavioral health that is actually in development. We're kind of in the final stages and are going to be piloting that. So stay tuned on that. That is a really high priority of ours. You know, I think that it has been a priority, but has just been exacerbated by some of the things we're seeing in our communities related to COVID and mental health and behavioral health concerns. So.
Great, thank you, Stacy. Another question, what happens to the referred but not screened patients?
So a lot of the times we do get patients who they're referred to us, but they're not interested in being screened. Perfectly okay. So if they're not interested in being screened, we're not going to say, no, we don't have any resources for you. We can't provide you with a referral. We definitely still are able to provide them with services. It's just, we don't get that data is pretty much what it is, but we still provide them with services. We still move along. The CHWs are working really, really hard right now to make sure that every patient that they do get in contact with, they can screen. But you guys only got to see one little piece of our screener. Our screener is a little longer than that. We've since adapted, adjusted, made a lot of changes to it as we've gone along based on what we've seen that the community needs or what we've seen our patients need. And so if they're not interested in filling it out, it's okay, but we do really try to get them all screened.
Great, thank you, Yesenia. This next question is a two-parter, so stick around. So yoga, meditation, and breathing practices show research benefits on prevention and treatment of hundreds of health conditions, including physical, mental, behavioral health, substance use, and trauma. What could it look like to integrate this into training for CHWs? And the second part is, but for now, has the idea like this come up before in any of the CHW studies or interventions you have done or imagine doing in the future?
Yeah, that's a really great question. I think we have maybe two answers to that. You know, some of those tactics are used in the lifestyle change program with the diabetes prevention program. And I was actually in a conversation yesterday around, you know, can SUHI work on developing a training for community health workers around kind of more of that wellness prevention side of things that I think we are really going to work on kind of figuring that out. So while we haven't, you know, I would say that I think tactics like that and that whole wellness approach is weaved within our interventions. You know, it is I think going to be an emerging focus for us into the future. Thank you for that question.
Awesome. Yes, very good question. I'm going to combine the next two questions as I think they are very related. So what do community health worker qualifications look like? As in like education, are there any other criterias? Can someone be a CHW in public health with a bachelor's degree?
Yeah, I think that you know, the beauty of the community health worker is that we really look for individuals such as Melinda, and there are a lot of other of our CHWs in this session right now that have those skills that are you know, hard to put on paper, but you know, people who can really connect, have a passion for this work. You know, resourceful, and really, so there really isn't a degree, for example, that we look for a community health worker. Our community health workers come from all different types of backgrounds, and you don't need a bachelor's degree, perhaps a high school diploma. I know some other organizations don't require that, but really looking for those folks that have those skills to be effective in the position. So I don't know, some of my other colleagues want to add to that?
If I may.
Yes, Kim, go.
I saw the comment come up in the chat box, and it was like, for people who are going into community health work, I know because of the medical background, you feel like this role is not for me. But for all of us who do this work or who have embarked on this work was given the training that they needed to do it effectively. The requirement as a community health worker, the standard, and I know they gave the definition, is someone who looks like the community, has a deep understanding of the community dynamic, and can communicate in a way that would allow a connection between healthcare and the community. You don't need that degree to qualify you to do this work, because a lot of this stuff is things that are inside you already, that help, that compassion, that innate ability just to connect and want to do more for your community members. Having that paper is extra, but not necessary to do heart work. And I mean HEART, passion work, for those that we serve. So if community health work, because of this presentation, is something that's on your radar, include yourself in the number, because you can learn to do the role. And as long as your passion is there and the desire to change and move things forward is there, you can do it.
Well said, Kim. Thank you.
No worries.
Awesome. And I definitely want to second that, Kim. All of our community health workers at SUHI, if there's one thing that links all of them together, is their passion for their communities. I mean, that's something you can't objectively measure, right? And I think that's that tangible that you, as a community health worker, we have at SUHI, right? Is that passion for our communities, which is amazing. So we have a couple more questions. So please, if you have any more questions, put them in the chat box. So our next question is, you mentioned CHWs are cross-trained. Can you talk about this a little bit more?
Stacy, you're gonna?
No, go ahead, Yesenia.
Me. Okay. So our CHW cross-trained, excuse me, meaning they are trained in multiple different programs. So for example, we can take Melinda, who presented with us today. Melinda's not only trained to work in the ED and trained to run on social determinants of health, she's also a lifestyle coach and trained in DPP. So say we have someone who comes into the ED who needs some help with diabetes management. Melinda would not only be able to screen them and work through the process, she'd also would be able to help them with the diabetes management end. So when we say cross-trained, we mean they are trained across multiple programs and they're able to deal with multiple issues.
Great, thank you, Yesenia. I also want to highlight a few things in the chat. One, Erica mentioned a bill that's been sent to the governor that includes language about CHW in regards to certification, training, and possibilities for reimbursement. So that might also be a good read. And also another comment from, I'm sorry if I'm mispronouncing your name, but Gaila, how they imagine that a community health worker would be a person the community looks for leadership and guidance. And that's a good point, right? Is that needed? I think that might dissuade some people from being a CHW if they think they already need to be that established person in their community. Can anyone speak on that a little bit more?
I mean, I think that comment just really sums it up, is that is the purpose of a community health worker, is somebody who has knowledge of the community, is a leader that people can really look to connect, community and individuals with healthcare and other social service systems. I do want to put a pin on this legislation that was mentioned, because this has been so long in the making, and it is on the governor's desk if it hasn't been signed already. But we are moving toward, and there are a lot of collaborators in there, and I want to give a kudos to all those who are involved with the Illinois CHWs Association, because we are moving in the state of Illinois towards CHW certification, and looking at reimbursement mechanisms for CHWs. And this really has been a long time in the making, and a lot of people involved. So I want to say we're making great progress, and so I'm really excited about the future and the sustainability of this really, really important individuals in workforce.
Awesome. So next question, how did your partnership, so you mentioned your partnership with social work ED, so how did this partnership change things for the emergency department team? And can you say how it was, maybe your team worked before the partnership and after the partnership?
Melinda, you want to answer this together? Because I feel like you definitely know even more too. The social work partnership changed things immensely for us. One, it led to a lot more integration within the system, which was of course on our radar from the beginning. But two, it also led to, I don't want to say less anxiety and stress, but I feel like less of, yeah, you're shaking your head, less anxiety and stress, I think, for the CHWs, because, if anyone's ever been to an emergency department and, as a patient, as someone who works there, it can be hectic in there. It is its own, team. They're their own. It's just, it's hectic. Alarms are going off. People are coming in. And then especially at Sinai, we are a trauma one, right? So it's also, it's a little different. And so to have that partnership, to be able to not just pull our CHWs out, but have them there and have them in other floors so that they could have that relaxation and kind of that not as worried and as much anxiety as they had was big for us too, because we are caring about our patients, but we also care about our CHWs. And because if they're not being cared for, how are our patients going to be cared for? So we need to make sure that both are good. Melinda, you want to answer a little bit more about that?
Yeah, so connecting with social work and Nellie, we did the rounds with them in the morning, so we were able to learn about each of the patients, why were they there, and Nellie was able to, she kind of directed us and let us know which patients she thought could use our services. So it was, I guess, it was a good connection to connect with social work. It was a much, I think, fluid flow, and we weren't in, like you said, in the ED where it was hectic and it was, it was traumatizing to be in the ED. I don't think we were prepared for that.
Awesome. And because of time, I do want to get to this question. I think it's a good way to end our conversation. Are CHWs more in demand now more than ever, considering our current circumstances?
From my perspective, overwhelmingly, yes. I think my colleagues would probably agree with that, given what we're seeing both, in our hospital system, but also in the community, and this awareness that we've known all along about the health inequities. COVID has really shined a spotlight on that. And so, I do believe, I think the CHW workforce and what community health workers contribute the awareness has certainly built. And, I think yes.
If I could just add too, I think navigating the healthcare system for someone who is not in the medical profession is so intimidating. And I think that's one of the key roles then that the community health worker can play, is taking a very complicated, very intimidating system and making it manageable and alleviating fear and making the people that are dealing with some really difficult, life-altering issues feel heard, feel less fearful, and certainly feel like they can manage all that's going on.
Fantastic. So Yesenia, Melinda, Stacy, and all of SUHI's CHWs. Thank you all for all of your amazing work.